Thank you very much. Thank you for that nice introduction and for the opportunity to speak today. As you've heard, I'm a family physician practicing in Toronto, and I have an interest in genomic medicine and how family history and genetics can play a role in more personalized screening and management. So it fits very well with talking with you today. Can I have the next slide, please? I have no relationship with any commercial interests. And the next slide. So my objectives today are really to help you become familiar with the types of family history that would indicate earlier screening and possibly a genetics referral, and to really talk about the important role of the primary care provider in colorectal cancer screening. And then, as mentioned, I'll talk a little bit about GECKO and some resources for colorectal cancer risk assessment. Next slide, please. So we've heard a little bit about this from the previous speaker, about the fact that up to about 30% of colorectal cancer is due to multiple shared hereditary and environmental factors. Next slide. However, only about 5 to 10% of colon cancer is due to inherited variations in genes that are associated with defined genomic syndromes. Next slide. So you've heard a bit about Lynch syndrome as an example of a hereditary colorectal cancer syndrome. So Lynch syndrome, some of you family physicians like myself may have heard about this as its previous name, which was hereditary non-polyposis colorectal cancer, or HNPCC. But that name is gone, and it's now called Lynch syndrome, named after the physician who really defined it. So Lynch syndrome is an autosomal dominant hereditary cancer syndrome that's associated with an increased lifetime risk for colorectal cancer and other cancers, particularly endometrial or uterine cancer. The risk of cancer and the age of onset of the cancers varies with which gene has the variant. And I've listed the genes here that are associated with Lynch syndrome. The prevalence of this syndrome in the population is about 1 in 279. So if you take a family doctor with a panel of about 2,000 patients, they should certainly have some families with syndrome. I myself have 2 families in my practice with Lynch syndrome. Next slide. The rarer hereditary cancer syndrome is familial adenomatous polyposis, and you can see its population prevalence is much lower. It's also autosomal dominant, and hundreds of thousands to thousands of adenomatous polyps develop, beginning very young at the age of 16. And by age 35, about 95% of affected individuals will have polyps, and without colectomy, cancer is inevitable. So I'm not going to be talking much about this cancer syndrome because it's much rarer. So we've already heard today about some of the colorectal cancer risk factors like lifestyle, diet, and weight. Next slide. I'm going to be focusing more on family history. So I think we've already heard that one first-degree relative with a colorectal cancer diagnosis is associated with a 2 to 4 times increased lifetime risk of colorectal cancer. And there's a greater risk with more affected relatives, a younger age of diagnosis, or the features of an inherited syndrome that I'm going to talk about soon. Next. Screening, unfortunately, screening for colorectal cancer is suboptimal despite proven mortality reduction. Our recent review showed that there was a less than 50% adherence to recommended guidelines for the age to start screening and the interval between screening among people who have a colorectal cancer family history. Next slide. So let's talk about the screening guidelines. And again, I know there's lots of talk about this from the last slide, but just to remind you again that in Canada, the screening for average risk individuals, so individuals who are asymptomatic, who have no colorectal cancer diagnosis in a first-degree relative, and no personal history of cancerous colorectal polyps or inflammatory bowel disease, is either a FIT test or an FOBT test every 2 years, starting at the age of 50. And we've just heard a really excellent discussion about the pros and cons of moving that to 45. Or, of course, flexible sigmoidoscopy every 10 years. Next slide. I want to highlight the different guidelines for screening for patients who are at increased risk. And in this slide, we're excluding the hereditary cancer syndromes. So with one first-degree relative with colon cancer of any age, colonoscopy should start at age 40 or 50. Again, it's controversial across Canada. But what is not controversial is 10 years younger than the age of the first-degree relative at diagnosis. If there are two or more first-degree relatives, then colonoscopy starting at age 40, or again, 10 years younger than the youngest diagnosis. But for second-degree relatives, one or more, the screening recommendations are those for the average risk population that I mentioned in the earlier slide. Next slide. But you'll see the big difference with the hereditary syndromes. So in screening for patients with Lynch syndrome, the screening recommendations vary depending on which gene is affected. So for these genes, MLH1, MSH2, and EpCAM, the recommendation is to start at age 20 to 25, so obviously much earlier. And to consider screening for some of the cancers that are outside the colon. And here, this screening, again, is controversial somewhat, but depending on personal and family history. So here I'm talking about, for example, ultrasound screening for endometrial cancer, doing screening urinalysis with cytology for individuals who have either family history or personal history of renal cancer, and prophylactic or risk-reducing surgery. Next slide. This slide is just showing the screening for the other pathogenic variants for Lynch syndrome. And in this particular case with MSH6 or PMS2, screening starts a little bit later at 30 to 35. But again, the really important feature here is that family history or the presence of a hereditary cancer syndrome really changes the age at which screening begins. Next slide. So I thought we might take a couple of cases to illustrate the kind of family histories that are suspicious of a hereditary colorectal cancer syndrome. So let's move to the first case. Oh, I think we missed who he was. We go back one? Oh, maybe not. Okay, no, sorry, go on, my mistake. So just thinking about how to diagnose a hereditary cancer syndrome. So here I'm just saying it's as easy as 3, 2, 1. So the question is whether there are multiple diagnoses in a family. So you're going to be more suspicious of a hereditary cancer syndrome if the family has 3 or more of the cancers that I've listed here in the boxes. If there are at least 2 affected generations, and if there is one diagnosis younger than the age of 50. Next slide. Other red flags that should be considered if you're thinking that the family may be a hereditary cancer family is if there's colorectal cancer diagnoses in someone younger than age 35, if there are multiple primary cancers diagnosed in an individual. So for example, if an individual has both colon cancer and endometrial cancer, if there are 10 or more adenomatous polyps, or of course, if there's a known pathogenic gene change in the family itself. Next slide. So here we are at Connor. So Connor is going to be my first case example. He's a healthy 26-year-old. He books a telehealth visit because we're during the pandemic where we're doing a lot of things virtually to discuss back pain. And the family doctor takes the opportunity to update his family history, which he is going to email back to the family doctor. Next slide. So I'm taking this as an opportunity to just highlight key family history questions for adult patients, where really if there's a yes response to any of these family history questions, it should prompt a more targeted family history about additional relatives and more details about the diagnosis. So this obviously doesn't just apply to colon cancer, but looking whether there's a history in the family of death before the age of 50, of a cancer diagnosis before the age of 50, of early heart disease, or particularly if there are inherited conditions or chromosome disorders in the family. So we asked this question to Connor, and the next slide will show his examples, his answers. So you can see that Connor does describe that there is a history in his family of a cancer diagnosis before the age of 50. Next slide. So this is Connor's family history or pedigree. And this is really to stress that it's really important when you're collecting family history, both patients and family and healthcare providers, to do a 3-generation family tree. Can I have the next slide, please? So here we're illustrating the 3-2-1 rule. So if you look at this family history, where the solid black shading is a relative that has cancer. And you can see that there are multiple diagnoses of cancer in this family. We've got 4 on the paternal side who have colon cancer, endometrial cancer. So multiple diagnoses, at least 2 affected generations. We've got 3 affected generations in this family. And you can see there's 1 diagnosis in a cousin of endometrial cancer at the age of 40. So 1 diagnosis under the age of 50. So this family meets our 3-2-1 rule, suggesting that it quite likely is a family where there may be Lynch syndrome. Next slide. So knowing that this might be a family where there is Lynch syndrome, what do you think the family doctor's next step should be with Connor? And so here I'm not doing the formal polls. I'm just going to get you to think about the answers to these questions, and then I'm going to show you the answer in the next slide. So what might the family doctor do? Nothing at this time. Refer Connor to a gastroenterologist, offer referral to genetics, or send Connor for a colonoscopy. So think about what you would do. Next slide. So the answer I'm hoping you said is to offer referral to genetics, and I'm going to show you why in the next slide. So we're talking again about Lynch syndrome, which you've now heard several times is the most common inherited cause of colorectal cancer, that accounts for up to about 4% of colon cancer and about 2 to 5% of endometrial cancer. And what's key about this is that it results in an increased lifetime risk for several cancers that I've listed here. And if you look at the table below, I'm showing you the lifetime cancer risk of a carrier of 2 of the gene mutations, showing you the risk of colon cancer and endometrial cancer compared to the general population lifetime risk. And you can see what a greatly increased risk there is of these cancers in people who have these gene variants. And you can also see that the median diagnosis is much younger. So again, stressing the importance of identifying these individuals so that they can be offered earlier screening to make a difference. Next slide. So Connor's family history meets the criteria for a referral for genetic assessment, as we've said. But interestingly, Connor himself would likely not be offered genetic testing because he's an unaffected individual. So this is a really important point about genetics referral, that genetic testing is generally offered to the youngest individual who has the disease in question, in this case, cancer. Because if they find a variant or mutation in that person, it's most likely that's responsible for their cancer. So as a family doctor, I would be encouraging Connor to talk with his family members and see if one of those individuals with cancer would be willing to see a geneticist and consider genetic testing. Next slide. So why that is so important is that for Connor, without knowing any of his genetic testing results, the screening recommendations for him, because he has only second-degree relatives with colorectal cancer, would be doing average risk screening, so with FIT or colonoscopy every 5 to 10 years. So it's going to make a huge difference on his age to start screening if we find out that he actually carries one of the Lynch syndrome variants. Next slide. So this is just pointing out that if we find out that he does carry Lynch syndrome, then the recommendation would be colonoscopy beginning age 20 to 25. So really much younger than if we don't know history. So what should we do? Let's look at the next slide then. So Connor's aunt, with my recommendation that someone in the family should really consider being tested, she tests positive for an MLH1 pathogenic variant. So my next question for you, because you're seeing Connor, is what's Connor's chance to also carry this mutation? Is it 0%? Is it 50%? Is 25%? Or is it not possible to know? He's trying to figure out what his chances are. Next slide for the answer. So his chance is 25%. And the reason for that is that it's quite likely that Connor's paternal grandfather carried this variant for Lynch syndrome. So that meant there was a 50% chance of passing that on to Connor's aunt. And of course, a 50% chance that the father could have passed it on to his son, Connor's father, as well. So that would mean that Connor has a 25% chance. Now, if Connor's dad actually carries the variant, then Connor would have a 50% chance of carrying it. Next slide. So we're going to move on to Cami, but just to point out the points from that case of Connor are really the importance of taking family history, identifying a family that's at high risk of being a hereditary cancer syndrome family, and then offering genetic testing to appropriate individuals to determine their risk, and then offer more personalized screening, which in this case, of course, would be at a much earlier age. Okay, so let's talk about Cami. I just have two cases. This is one to illustrate a slightly different point. So Cami is a healthy 35-year-old who comes in for a routine office visit, and she also takes a chance to update her family history. Next slide. So again, you're going to ask the key family history questions, or the patient may well have brought those in. And next slide is going to show that Cami answers basically the same as Connor, that there's a history of a cancer diagnosis before the age of 50. So you're going to ask a few more questions. Next slide. So here is Cami's family history. So using our 3-2-1 rule, you can see there are not multiple diagnoses in the family, and there aren't at least two affected generations. But the significant family history point here is that Cami's father had colorectal cancer diagnosed at the age of 47. So this fits our red flag of one diagnosis at a younger age than the age of 50. Next slide. So what might the family doctor's next step be with Cami? So we have one relative at the age of 47. So what might the family doctor do? Nothing at this time, refer to gastroenterology, offer referral to genetics, or send for a colonoscopy themselves. What do you think? Let's show the answer on the next slide. So I'm going to suggest nothing at this time, but let me tell you my thinking. So the next slide, please. So thinking about this, it's certainly possible that Cami's father may meet the criteria for genetic assessment depending on his tumor pathology. And our last speaker and several others talked about this a little bit. So certainly in some regions of Ontario, and certainly in all of Ontario and some regions of Canada, colorectal cancer tumors are being tested reflexively, so automatically, to see if they carry some of these genetic markers, like microsatellite instability. I'm not going to go into the details of this because it's not my forte, but about 90% of Lynch syndrome associated colorectal cancers are microsatellite high tumors, compared to about 15% of sporadic tumors. So if his tumor illustrated this, it would suggest that he should be considered for genetic testing for Lynch syndrome. And or some tumors are tested for immunohistochemical staining. And this is evaluating for expression of the proteins that are created by these mismatched repair genes that are causing the cancer. So again, if his tumor were tested and found to carry these markers, we might then be tested for Lynch syndrome, which of course, if we were positive, would have a different outlook for Cami, since there'd be a 50% chance that he could pass that on to her. Next slide. So for Cami with a first-degree relative with colon cancer under the age of 60, she would be recommended to have colonoscopy starting at the age of 40 or 10 years younger than the youngest diagnosis. But the important point here is that she would be eligible to begin screening at the age of 37. So again, in our talk about screening people early, I'm stressing the importance of family history to highlight the different age at which screening should happen in these ages. Next slide. I also want to comment that having a physician recommend screening has been found to be one of the most important predictors of screening adherence, and it increases the likelihood of screening by 5 to 27-fold. So a really important message to any healthcare providers in the audience. Next one. just want to take 2 slides to comment on a project that my team did, which was following a 10-year cohort of patients who had a family history of colon cancer and their family physicians in Ontario and Newfoundland. So we followed this cohort of patients over 10 years, which is almost unheard of. And over the 10 years, 2/3 of the patients, so all these patients had a family history of colon cancer, 2/3 of them received the correct colorectal cancer screening test at the appropriate timing. So you can say, I guess you can look at this glass half full or half empty. So it's good that 2/3 did, but a third did not. About half reported that their family physicians recommended colorectal cancer screening. So we don't know if their family physicians truly recommended, because I can tell you in the surveys, the family docs all said they did. But they're not all getting the message and just the importance of a family physician's recommendation about this. I can't recommend strongly enough. Fewer than half the patients correctly assessed their colorectal cancer risk based on their family history. And of those who incorrectly assessed their risk, about half underestimated. So that's an important point as well. Next slide. The patients in our study were less likely to have the correct timing of screening if they were female, and less likely to have both correct test and timing if they were at moderate to high risk of colorectal cancer. So this really is a message for primary care providers to really focus attention on these individuals, females with family history and people who are at moderate to high risk due to family history, as they're the people that are most likely going to benefit from screening. Patients were also, again, far more likely to have both correct test and timing if their family physician recommended it. Next slide. So the challenge, of course, especially for family physicians, is that the prevalence of hereditary cancer is low. The prevalence of one or more first-degree relatives with colon cancer is about 3 to 10%, and the prevalence of having 2 or more first-degree relatives is less than 1%. So they may not think of it. It may not be on their radar. So it's going to really stress what a number of the patients said in their stories about advocating for yourself and telling your family physician about your family history, plus asking your family about the family history. Next slide. Future trends, we've been hearing about some of these from the last speaker. I think risk prediction tools in the future will use more than age and family history. One tool that's out there now is called Q-Cancer, which incorporates personal and family medical history as well as current symptoms to give a risk. Next slide. Because of my interest in genetics, I'm really interested in polygenic risk scores. So these are risk scores that they're large studies looking at single nucleotide polymorphisms that are more common in people who have colon cancer in this case than in controls. So people would, in this kind of idea, people would have a saliva test to find out their polygenic risk score for colon cancer, let's say, and then that would be combined with age and family history to give a recommendation personalized screening program. So those identified at higher risk by their genetic profile would perhaps have earlier screening and may be more likely to participate in screening. But of course, those identified at lower risk may be able to avoid unnecessary screening. Next slide. So in conclusion, I can't recommend strongly enough the importance that family physicians and primary care providers recommend screening to patients. To provide personalized information about colorectal cancer risk, because this has resulted in increased screening, particularly in those with a family history. I think we need to pay particular attention to female patients with family history and those at increased risk due to family history, and identify those who may be in a hereditary colorectal cancer family, because they certainly need earlier screening and may benefit from genetic testing. Next slide. I'll just finish with the last 2 slides telling you about how to find more information about genetics, particularly appropriate for primary care. This is my website, which has educational information about genetics. And next slide, just featuring, we have information on Lynch syndrome and hereditary colorectal cancer. Next slide. This is just illustrating the resources on Lynch syndrome. They're all highly suitable for primary care providers. And then the last slide is just my contact information. And thanks very much.
Dr. Carroll, thank you so much particularly for sharing the resources which are available at the end. We will be sure to be sharing all of this information following the symposium as well. in various different formats. So much appreciated. We do have one question that I hoped you would take a moment to answer. The question is this: have you had any patients present with a sporadic hereditary syndrome with no family history of a hereditary syndrome, but themselves presented with a hereditary syndrome?
So I think you're saying somebody presents with cancer and then we find out that they actually have the hereditary mutation. Is that what the question is?
Yeah, I certainly don't want to do a medical interpretation on that question, but I'll read it again and perhaps you can help me decipher it.
Sure.
Have you had any patients present with a sporadic hereditary syndrome with no family history of a hereditary syndrome, but themselves presented with a hereditary syndrome?
I think I understand that. So that last case I presented might be that case. So that Tammy's father, so he would have presented at the age of 47 with a tumor. And on pathology testing may have been found to have some markers that would fit with Lynch syndrome, and then could have been found to have Lynch syndrome. And in his case, he had no family. So yes, that's not my personal case, but that case example certainly would illustrate that. So yes, it can certainly happen. And remember, the other thing is everyone doesn't know their family histories. Some people are adopted.
Yes.
Some people, for various reasons, just don't know their family histories. So I don't think that we should ignore the possibility of a hereditary syndrome just because there isn't a family.
Right, right. So I loved your very simple message, which was females with family history with modified to high risk should be singled out a little bit more prolifically. Thank you again, Dr. Carroll. I do want to reinforce that in the download, there is a resource hub on this virtual platform. There is a physician kit, as we've called it, that's been created for this symposium. It's really for physicians to share with patients, and it's all about awareness building and awareness creation for early onset colorectal cancer.